It's an honor for me to introduce the Felix Battistella Memorial Lecture. For many of you in the room, Felix Battistella is really the name that's on the meditation room there on the first floor, and his picture and saying are up on Davis 11. But Felix was much more than those two things. He was a father, a husband, a surgeon. He was the chief of trauma. He was the residency program director. He was a friend. He was larger than life. As a little intern on the old Davis TNU, he loomed large over you all the time when you round it. And the one thing that he always would say is, just do the right thing. Now, just do the right thing is a fantastic saying for a surgeon and a surgical educator, because it distills down what we do into the simple phrase of just do the right thing. It wasn't just do the scientifically based thing, or just do the easy thing, or just do the financially sound thing. It was just do the right thing. The right thing really was from the patient's perspective and the care that they wanted. It wasn't about whose job it was to do that, or what service the patient belonged on to, or what the insurance said about getting the patient back. It was just do the right thing. And the saying, just do the right thing, is as applicable today as it was 12 years ago when we lost Felix. So it is an honor, again, to introduce this lecture. I'm going to turn it over to Dr. Farmer to introduce another fantastic educator who we were very cognizant to bring because of what he represents in comparison to Felix. So,
thanks, Joe. David Spain was actually invited to give this lecture before coronavirus. So it had nothing to do, in fact, with the fact that we were next door neighbors, but due to the fact that he was selected as the very best person that we could think of to be the Battistella visiting professor this year. He's currently the president of the AAST, so most of you who know trauma, because it looms large in our particular department here, is the biggest, most important, and prestigious, and most influential, in fact, trauma organization. We're proud to have another West Coast person be that president. Dr. Jerkovich has served in that capacity, and many in our region. Dr. Spain hails from the Midwest, went to Michigan State, home of Magic Johnson. Actually, I should say Magic Johnson, home of David Spain, but and many other illustrious folks. Then went to Wayne State. We shared a spiritual crossover in Detroit. Appreciate that that's really an extraordinary city that is undervalued by many. Before he went on to his general surgery residency at the Robert Wood Johnson training program, and then a trauma critical care fellowship at Louisville. He's been at Stanford since 2001 and really has developed an outstanding trauma program there. But for this purpose, we really honor him as an educator and the commitment, a lifelong commitment to education. He and I crossed paths through his tremendous service to the Northern California chapter of the American College of Surgeons, then on the program committee, really trying to make that whole college experience meaningful from an education point of view, really always being the voice for, are we doing the right thing, as Joe said, around education as well. So with that, it's a true honor to bring my friend and colleague and most respected trauma surgeon, Dr. Spain.
He's getting set up here. One of my favorite scenes is in Spike Lee's movie Do the Right Thing, right? So Spike Lee's walking down the street, and the old guy on the stoop looks at me and goes, tells him, I'm going to drop some knowledge on you. He goes, you ready? Yeah. Just do the right thing. That's it? That's it. I got it. And then he walks away, right? It's a great scene. All right. Well, it is a tremendous honor to be able to give this lecture. I really thank Dr. Galante, Dr. Jerkovich, and Dr. Farmer for inviting me to come do this. And first of all, it's the first time I've been outside like 10 miles of my house in 5 months, so I was pretty excited to actually get in my car and drive up here. So my actual title is the David L. Gregg Professor. Dr. Colcutt and Dr. Mel will tell you that Dr. Gregg was an incredible, he is an incredible character, but he was in private practice general surgeon at the Menlo Clinic. And when I got to Stanford in 2001, he was taking general surgery and trauma call. And I'm like, who is this private practice guy? I'm like, on my trauma panel. But he was a great guy and a great surgeon. Still holds the land speed record for the fastest laparoscopic appendectomy at Stanford. I think it was 14 minutes. I did one a couple weeks ago that we were screwing around. We did it in 17 minutes. I was like, I should have gone faster. But he retired from private practice in 2011 and then worked full-time with us until he really retired in 2018. Seems like it was longer than 2 years ago that he left us from his clinical work. And the endowed chair that I hold was actually given by a grateful patient that he took care of. And they were actually friends. Like, they went to elementary school and grade school and high school together. So they'd been friends their entire lives. This gentleman got hurt. David arranged for his care. And then the patient wanted to give a gift. And so I met with him, and he had this number in mind that he wanted to give, and somehow he made some statement. And I said, well, there is a way you could honor your lifelong friend with a gift that would stand forever. He looks at me and goes, what does that mean? And I told him the amount, which was about 3 times what he was thinking. And he looks at me and he goes, let me talk to my wife. And I knew what the answer was going to be. And so then this patient and his wife gave a gift that endowed this chair, which will forever be the David L. Gregg Chief of Trauma at Stanford. Why am I telling you this? Because David Gregg finished his general surgery residency at UC Davis in 1979. He arrived here as an intern when Blaisdell came to be chair, spent his entire residency here with Dr. Blaisdell, who we recently left, who was also a radical thinker. And so just know that forever the chief of trauma at Stanford will be named for a UC Davis trainee. So Felix and I were the same age. He was about 6 months older than me. We knew each other professionally for quite a while. Really connected when I moved out to California, and I still remember he had me up here in 2004, and we spent the day together and went out to lunch, some outdoor cafe in the fall. It was just a beautiful day, and it was great to spend the day with him. And as I was getting back, I reflected back about this, and I actually came to Felix's funeral in 2008, and it still gives me goosebumps. I think about it 12 years later, about what that day was like. It was pretty spectacular. But going back, I looked and it was incredible, like some of the things we had in common. So, I went through our CVs and things we wrote about, and so, post-traumatic empyema, video-assisted thoracic surgery for trauma back, in the late 90s. Increased use of DVT prophylaxis with filters, perihepatic packing, volume outcome relationships, and the whole idea of, acute care surgery and training in emergency general surgery. So lots of very similar interests that we overlapped on. But again, as Dr. Galante said, the thing that really stood out about Felix was he was an incredible teacher, just a gifted educator. So I always said when I retire, I want people to say first that I was a good surgeon and maybe even a healer. And then second, I'd like to say people to say I was a good teacher. And then third on the list, I'd like people to say I was a good researcher, in that order. So, giving talks like this are really challenging. So it's pretty intimidating, right? So what can I tell you guys about clinical care or research that you probably, don't already know, or probably, already do better than we do? And so it's really challenging to come up with a great topic. So I'm going to take a short digression, but I kept coming back to the idea of Felix as a teacher, and that's the one that kept sticking with me. So I'm going to take a little short journey here to get you to today's topic. So John Dana was a librarian, basically. So he was born in Woodstock, Vermont, in 1856, very established New England family, and went on to study law at Dartmouth. And then he moved out to Denver, Colorado, because he had asthma and moved out there for the air and for his health. And passed the bar and practiced law there. And he moved around a little bit for a few years, got married, never had children. And after moving around for a little bit, he actually came back to Denver in 1889 to become their first, basically, librarian for the city of Denver. And he served in that role for about 9 years. Then he moved back to New England, to Springfield, Massachusetts, where he held a similar position for like 4 years, and then ultimately settled in Newark, New Jersey in 1902 to be the leader of their library system, a role he held until his death in 1929 at age 73. And then during that time, he also founded the Newark Museum. But Dana was a maverick, right? So in Denver, he pioneered the first ever children's collection of books. So the first children's library in the United States was in Denver. In Springfield, when he was there, he took down the railing. So back then, there was a small entryway. There was a railing. And if you wanted a book, you had to like tell the librarian, and the librarian went back and got the book for you and brought it out to you. And he thought that was wrong. He thought the shelves should be open and people should be able to just wander through the stacks and look at books and get the books themselves rather than relying on the librarian to do that for them. And then in Newark, he lengthened the hours so working people could come to the library after work and made it easier for them to get a library card, so it wasn't a thing of privilege. He actually established a foreign language collection like in the early 1900s for immigrants, which you think about is pretty radical. And then he developed the first special collection for the business community. So he really established the first specialty library for business while he was in Newark. He was also a social maverick. So in the early 1900s, he said every woman should be trained for a job and should take every advantage to be independent. No woman should be accountable for taking care of their parents any more than any man should be. So this was in the early 1900s. So he was a pretty radical thinker, pretty out there. But my favorite quote from Dana is this one, which is, "Who dares to teach must never cease to learn." So this one kind of stuck with me. So I want to talk a little bit about who dares to teach today in honor of Dr. Battistella. So we'll talk a little bit about learning environment, what it means to be an effective teacher, and a little bit about what it means to be an engaged learner. So we have to start off with the first premise, which is excellence is the foundation for any teaching in surgery is excellent patient care. All right? We all have to start with that, whether you're attending, the resident, the student on the service. Excellent patient care is the foundation for all teaching that we do. So, surgical teaching has been going on for a couple hundred years, correct? Like back in the old days when surgery was basically apprenticeships, until today. And it goes on in various forms. Obviously, we do a lot of OR teaching. Dr. Rinderknecht's here. That's Dr. Forrester, your co-chief, doing a case with me recently. We do a lot of bedside teaching, right? This has also been going on for years and years, and then occasionally even a formal didactic lecture. Famous Dr. Jerkovich there. So, this has been going on a lot. But things change. So intraoperative teaching is still the most important thing we do. It's still the best thing we do. I tell the residents, if we're in the OR and you're doing a case and I'm talking to you, that's called feedback. But Socratic teaching and didactics are also important, right? And, most recently, there's been a big push to incorporate simulation. And this has really coincided with the introduction of laparoscopy. But, like I say, in most simulation, it can be pretty basic, right? You don't have to have fancy, expensive models. You can have low-fidelity models that actually work pretty well. So we use a lot of mannequins now to sort of simulate OR environments. Here you can look at me. I'm super engaged back here. But this one we're actually teaching our neurosurgery residents how to do crikes because they'd had a couple airway emergencies after neurosurgery operations. And then obviously some high fidelity, real simulation. Here's a central line module that we put all our residents through with ultrasound. So the old days of see one, do one, teach one doesn't really apply. So all our residents, before they can independently put in central lines, have to go through a simulated session where they learn the safety issues, do a number of them supervised before they're signed off to be able to do central lines. So again, none of this even existed. I was putting in central lines by myself as a fourth-year medical student at Detroit Receiving Hospital back in the day. But there also wasn't cell phones back then, or computers. So But things change, and so we've had to incorporate a lot of these different methodologies to teach into our teaching system. But as you guys know, sometimes low fidelity, simple models can actually be very, very helpful. So when Dr. Galante and group showed that you could actually simulate vascular injuries and develop a nice model that's relatively inexpensive. This was, compared to trying to use a cadaver model, which is extremely expensive. You can make your own little thing here. And, you look at that and you're like, well, it doesn't look super realistic. But I remember the first time I saw one of these people using simulation. And the case was a vascular surgeon doing a carotid endarterectomy. And it was clearly, the guy's doing it on a mannequin. He's on a tabletop. It's a fake mannequin. He knows it's fake. And they have the surgeon doing a carotid endarterectomy, and they had a EKG monitor on the surgeon. And the minute the surgeon cross-clamped the carotid, his heart rate went up 30 points. It's fake. It's fake, but it's the ability to suspend, disbelief, and simple models like this can actually do it. And then obviously, COVID-19, we have not yet done this. We have not had any in-person teaching for our residents or any in-person faculty. Everything is still remote. So this is the closest we came, where we had a little bit of a teaching session with our students recently. But all our residents, core course and everything, and grand rounds are all on Zoom and hanging around a computer. If you get ingenious, it works out pretty well. This is Dr. Dewar, one of our HBB surgeons, doing a little old-fashioned whiteboard lecture. It can work pretty well, but this is all stuff we've all had to adapt to in the last 5 months. I think which just goes to show that, your learning environment has to be flexible and adaptive, and you can't be too rigid. But this is, even before this is a study out of Japan where they were looking at just kind of a low fidelity, just a little model to coach people on how to do intracorporeal suturing and knot tying. And it's a pretty basic setup, a little acrylic stand, a little GoPro camera, and you can actually have somebody remotely watching you sew and giving you advice. There's no way you'd get me to volunteer to this one, watching me sew and tie intracorporeally. I do a lot of things like laparoscopically, but man, my intracorporeal suturing technique it's really bad. So, but there are ingenious ways that you can use remote learning. And I don't know about all this new normal stuff, and I think a lot of this is going to go back to the old way once we get vaccines and the like. But I do think there's some of these remote learning and video conferencing things that allow us to take advantage of remote expertise a lot more in the future. And there's always new things to teach, right? So there's new ways to teach, right? But there's always going to be new things to teach as well. So laparoscopy was really the first disruptive big force in surgery in almost 100 years. And this really, you guys are, most of you too young, Matt's probably about the right age, but I can remember when I was a third-year resident going to the library, getting a physical journal out, right, and reading the first report of 8 laparoscopic cholecystectomies done. And I remember reading that article thinking, oh, they just screwed up a perfectly good operation. And then really, if you go look at how that operation came about, and it was really all done incorrectly, right? It just it spread like wildfire, and a lot of people were doing it without much training. But it really was a huge disruptive force in surgery, and really just forced us to change the whole way we sort of teach things. And so, the ability to do laparoscopic surgery, like I say, was a major change. And just for Tanya, you pick up, that's Joe taking his younger brother Jared through a lap chole recently. And now with our fancy new ORs with the green lights, which I like, some people hate, but it makes it easier to see. And then now, we have the robot. So there are a lot of things where I can see an advantage of the robot. I personally am not going to learn how to do it. I'm too old. But it's been a huge change. And the question is how do you teach a resident to operate on a robot? And that's a major issue. And so we've kind of struggled with this one, and we wound up with this kind of 3-phase curriculum that we had to develop and implement, because residents were kind of showing up for cases on the robot and really didn't know the basics about how to run the machine, and like wanted to do the colectomy or something. And so we had to put in a whole thing about you got to take certain modules online, learn the safety things. You had to demonstrate certain skills in the simulator. Had to do a certain number of cases as a bedside assist. And then as you got onto the console, it's a negotiation, right? So the resident has to say, hey, I feel comfortable doing this part of the case. And attending will say, sure, we'll let you do those. And then we keep track of it all so we can sort of verify that people actually know what they're doing. But this is a whole new thing. Like there's a whole new adventure, and people are struggling with this. And this just came up on the program director's listserv last week that, program directors say, how do you verify that your residents can work on a robot? And so a bunch of people around the country have programs similar to this, and we're putting them online so that other programs could borrow and use them. And it really is a whole new thing that we've had to teach residents that none of us would have contemplated 15 or 20 years ago. And then the other thing that's really kind of struck me in the last couple years is that there's a whole lot of non-clinical things that we've realized that we need to teach our residents and medical school students about. And I think we finally realized that, especially in the last, even 6 months, that, healthcare doesn't happen in a bubble. And so, this whole idea, if you'd have told me 10 years ago that surgeons would be talking about the social determinants of health, I'd be like, what are you talking about? Like, it wasn't even on any of our radar as surgeons, or almost none of us, but it's right, but it happens, and we know it happens, and it's an important determinant of how our patients do, and so it has to be part of what we learn and what we teach our residents. And we've obviously in the last couple months, disparities in healthcare. This recent report that Black children 3 times more likely to die after surgery than their white peers. And these are all things, again, that none of us were thinking about even, 5 or 10 years ago, but clearly are important for our patients. And if we're going to be honest about what we're trying to do and provide excellent care, then these are things that we have to know about and address. And again, none of these are things we would ever taught trainees years ago. And then, obviously the whole issue of, non-technical skills. I will say, 90% or maybe more of the problems that residents have and that faculty have, it's almost never technical skills. It's not that you can't sew or tie. It's almost always interpersonal communication. What do you do when you get an incident report and there's a wrong count and everybody gets annoyed? Like it's all, it's almost all of the non-technical skills. So we've actually added a whole sort of coaching curriculum for our residents. Like our senior residents get assigned a coach to help them with their, and we have coaches that actually come and observe them in clinic and watch them interact with patients and families and help them sort of develop these non-clinical skills and communications and giving difficult news, as Dr. Jerkovich alluded to earlier. At some point in your life, you're going to have to go out and tell the family that you had a complication that was a technical error, or you left an instrument in the patient. And these are all important skills and the things that are most likely to get you into trouble rather than your technical abilities or your decisions to operate. And then obviously, the whole issue of unconscious bias and how it affects what we do and how we teach and how we select residents and all this stuff. These are all things that weren't on any of our conscience, even 5 years ago. So again, the teaching environment, I think, you have to be flexible. I think that there are more varied options now, and I do think that there's some, things that'll forever be changed. Like our Tuesday morning grand rounds, like I said, we're 100%, Zoom right now, which is terrible because we haven't seen each other and haven't get together. But I think at some point we'll probably do some hybrid things. So, because for our residents down at the county hospital, having to drive up and drive back down in the morning and traffic and everything. So I think there'll be ways we can use this to help some of the people, but still lots of varied options. And then simulation is, it's another big thing that we're using more and more. It's one of those things that makes a lot of sense to me intuitively, but it's still, there's a lot of time and effort it takes to use those. I think there's a real bias in them to laparoscopic and robotic teaching compared to open surgical skills, just because it's easier to do something on the lap laparoscopic simulator or the robots, simulator than it is to try and replicate an open operation. Although I don't know if any of you have been seeing these like little Play-Doh TikTok videos of Play-Doh surgery. Look, if you haven't seen them, they're pretty cute. But it's definitely tougher to simulate open surgical skills. And there's still a question: does it translate to better care and better outcomes? It's still not 100% clear. But man, it just sure makes sense to me that you should have to go to the sim lab and demonstrate like certain proficiencies and steps of a laparoscopic cholecystectomy before you're allowed to go into the OR and actually do it on a human being. Like that just makes sense to me. So we're working on it, but it's what is right now one of these unfunded mandates in surgical education that takes a lot of time and effort. But I do think it does make a difference. So after the environment, there is the effective teacher. And I think there are some master surgeons and master educators out there, and I think most of us know it when we see it. I think Felix clearly was one. Actually, Jerry's a phenomenal teacher. Dr. Jerkovich really, is a great, engaging teacher. My hero was Frank Miller. Frank was a surgeon at the University of Louisville, and just a phenomenal surgeon and a great teacher. And he won the Golden Apple Award like 10, 12 years in a row. And finally, they look, we got to stop this. We'll just name it the Frank Miller Teaching Award. So they did that. And then the chair of surgery looked at the rules and he's like, He didn't say Frank wasn't eligible. So the first year they had the Frank Miller Teaching Award, the chair nominated Frank Miller, and Frank won the award. So Frank won the Frank Miller Teaching Award first year. Then they said, no more, you can't win anymore. But he was a gifted teacher, just like an amazing human being and a gifted teacher. Just passed away a couple years ago, too young. But really was, for me, like I think all of us try to teach, all have that role model that we all had back when we were in our early days, and Frank was clearly, for as far as teaching, the one for me. But there's surprisingly little data out there about what makes an effective teacher. So, this group did actually a meta-analysis. So if there's not a lot of data out there, what do? You try to do a meta-analysis, systemic review. And basically, they found 23 studies, but about what made an effective educator, right? But 3/4 of them didn't even define what an effective educator was. So there really isn't a lot out there. I think it was clear for them, like some of the things that were common was that you create a positive learning environment and that you have excellent communication skills. So this is an interesting piece. Both these are just fairly recent, right? So this group, this is from University of Pennsylvania, and they basically surveyed the residents, and it's 77 surgery residents, and they sent them a survey and basically asked each one of them to nominate 3 faculty members that you thought were excellent teachers, right? So they got about a 56% response rate. About 35% of those who responded were women, and about 40% were senior residents. So that was kind of representative of the residency as a whole. And so these 43 residents each nominated 3 surgeons that they thought were exceptional educators. And out of the 70-something faculty that were eligible to be nominated, there were 58 men nominated and 14 women, and at least 45 of them got at least one nomination. So, and then they selected 12 surgeons who got the most nominations and interviewed the surgeons. So residents nominate, those got the most votes were interviewed. Now the biggest problem with this study is these 12 were all men, so that's a problem. So, and then they use this grounded theory model, and this is pretty common in qualitative research, and basically you interview people with open-ended questions, and then you analyze their responses through this inductive and iterative approach where you just keep going through them, and then you build on their experiences, and you generate these themes in a model, and then you keep doing that until the next interview doesn't add or change that model. and that's what they call data saturation. And so these 12 surgeons basically identified 4 central domains that they thought were important for effective teachers. So one was the patient, right? So we said the foundation of all good teaching is excellent patient care. There's also the learner, the educator themselves, and again, the culture of surgical education or the environment. And again, 12 of the 12 surgeons they interviewed said, that exceptional patient care was sort of the core tenet of all excellent education. So we get back to that idea that excellent patient care is the most important thing that we have to do. A lot of them said that they emphasize the idea of individualized learning, they try to adapt what they do to their specific resident or team that they're working with. Multimodality teaching being more important, simulation, lectures, hands-on teaching, didactics, Socratic method. And then also part of your teaching being this idea of pushing and trying to help with trainees with autonomy and independent thinking and decision making. They also thought it was for the educator themselves that education had to be important to you to start with, right? You had to have a love for the profession, and you had to have a prominent role model in your past. So Frank Miller for me, but most of these people who were thought of as great teachers had some strongly positive role model early on in their career. And then this the idea of the learning environment and what's the culture there. So there has to be a culture of psychological safety. This is one of those ones I'm like, what do they mean? But really it's like, do you feel comfortable asking a question? Like, so you're a resident, you're on service, you don't understand something, it's not making sense. Do you feel comfortable stopping Dr. Galante around and saying, wait a minute, I don't understand this, can you explain this to me? And then obviously accountability and collegiality, are we in this together? Are we working as a team? All these are important in the culture and ideas that can promote learning for the residents. And so these surgeons, chosen by their own residents, espouse the educational values that sort of support this cognitive-based learning. So we need to teach you what you need to know. And many of the derived themes like learner autonomy, accountability, previous mentors, and education all get back to the traditional sort of Halstedian values, right? That we all, and as such, they thought it was, they saw the utility of new approaches and individualizing things and creating a culture of safety and multimodality learning. And these are actually all good things to help prevent burnout, right? If you love teaching and love educating and have fun teaching the residents, it's self-preventive for burnout. So, but you can't ask me about burnout because it's never been a thing for me, and people talk about burnout, my eyes kind of glaze over because it's never been an issue for me, but I understand it is a huge problem. But again, and maybe it's because I love teaching and it keeps me excited and keeps me enthused about coming to work, and maybe that's why I don't experience it. But they also felt that what they got from these educators, it sort of demonstrated the importance of sort of dynamic and individualized approach. So, we increasingly like structure and organization and standardized things. But, a lot of what, one resident needs, what another resident needs in a particular situation isn't always the same thing. And so I think we've generally been good about sort of individualizing our approach to specific learners. And I think that, despite this push for everything to be standardized, that we still need to be adaptable and try to, adapt our teaching to the individual resident or team that you're working with. So now this study actually hasn't even been fully published. It's still like in press. And so the last study, they asked residents to nominate faculty, and then they interviewed the faculty. And in this study, they actually just interviewed the residents directly. So they took PGY 4 and 5s, and basically they used the exact same methods. They basically patterned this study off the previous one. But rather than having the residents nominate faculty and interview the faculty, they just interviewed the residents directly and asked them their opinions. And so in their program, they wound up with 13 senior residents that they interviewed, and they did this same grounded theory work. And they had as opposed to the last study where they interviewed 12 I don't think they said it, but I think it was 12 white males. Like, is who they interviewed. This one actually, they have a decent mix of residents here that they interviewed. And it only took 13, data saturation. And actually, if you look at sort of grounded theory things, 12 to 15 interviews is, for almost anything, is about what you need to do before you usually hit data saturation and can develop your themes. And so again, they ranked as most critical. This is residents' opinion of what an effective teacher is. Excellent communication, positive learning environment, timely constructive feedback, and then technical expertise in teaching of technical skills. Again, getting back to this idea that you got to have excellent patient care. And so they believe that effective educators recognize the importance of communication and a positive learning environment, and are able to adapt. And this idea of being able to adapt what we do to what the learner needs in that situation. And then obviously you got to have the clinical and technical expertise. And then you have to form a bond. And I think this is totally a different idea. When I was a resident, I didn't want to bond with any of my attendings. But times are different. Things are, people are different. We didn't have cell phones when I was a resident, right? I tell my residents my cell phone was a roll of quarters, and I just knew where every payphone was between the hospital and my apartment. So if I got paged, I knew where to pull over and put a quarter in the payphone and call the hospital. But it is a different time, and people have different needs, and so I think this idea of really bonding as a team and working together is becoming more and more important. So, again, as Cotton said, who dares to teach must never cease to learn. So how do I learn? I think I have 9 rules I go by. Number 4 is never stop learning. So, obviously, the greatest benefit of having residents and training residents is they keep you on your toes. Man, if you get behind, they're going to call you out. So, obviously, clinical work and having to teach in the ICU and around and being able to, up on the latest literature. So you have to, you have to read. I think scholarship and research helps, writing, editing manuscripts, grants, keeps you up on the latest literature. Obviously, reading, technical, clinical research. I think you have to try to read a little bit outside. So there's I try to read a lot of growth and leadership things, and I think you got to read for fun. I'm embarrassed to tell you, in the 8 years I was a trainee, I did not read one book for fun that entire time. And then lately I've been listening to some podcasts. I have a super short commute. It's 10 minutes. So it takes me about 2 days to get through an average podcast, going back and forth to work. But it's been my latest thing. So some of my favorite things, The Two in the Corner, The Contrarian's Guide to Leadership, one of my favorite books. It's a great one. It's a simple knockoff. You can read it in a weekend. Great book. Tyranny of Metrics speaks to one of my prejudices. And The 5 Dysfunctions of a Team is a phenomenal book. I think every resident and faculty should be made to read it. So we gave these to our entire trauma team, and we all read it. We actually did a book club and read The 5 Dysfunctions of a Team. And it's a great book. And and I just love the way he put the book together. A lot of these can be dry. He actually made up a fictitious company with a new CEO. And so the whole book is about her journey from coming into this company and not really fitting, and how the team wasn't working and how she worked through it. And so, it's almost like a fiction. It's a fictionalized novel, but it's a really great book about how to work together. And obviously, if there's 5 dysfunctions of a team, the corollaries to those are the 5 functions of a highly functioning team. It's a great book. Everybody should read it. And then I try to do some fun reading. So my favorite author is Robert Wilson. That's actually my favorite book of his. But I've read everything he's written, and they're all kind of suspense novels and all this kind of stuff. That's a great one. And my recent ones I've read, Let the Great World Spin, Everman. The Warmth of Other Suns, phenomenal book. It's incredible. And it talks about the great migration of African Americans leaving the South after the Civil War and Jim Crow era, and their migration to the North. It's an amazing book. It's long. It's like 700 pages. So it takes a while to get through it. But it's a phenomenal book. And then next up on my reading list, I'm going on vacation in 2 weeks, so these are going to be on my reading list. Actually, Wilkerson's next novel just came out, Cast. I just got it yesterday at home. Range, which is another one. This again speaks to one of my prejudices. I want to read this one. So why generalists triumph in a specialist world? For all us general surgeons, all of us who consider ourselves general surgeons, that's going to be one of my favorite. And then I read everything Malcolm Gladwell writes because I just think he's hysterical, and I love the way he thinks. So Talking to Strangers. So these are next up on my reading docket. I will say one thing we did recently that's been a lot of fun in sort of getting some scholarship and research going is, so I read this book like 2 years ago or a year and a half ago, and it's called How to Write a Lot, A Practical Guide to Productive Academic Writing. And Silva's like a PhD psychologist or sociologist, but it's an academic. And this is his thoughts on how you can be productive and how you can write a lot. And chapter 4 was about starting a writing group. So I bought like 50 copies of this book, gave it to my residents and said, here, read it. And a bunch of them read chapter 4 about forming a writing group. And they started we have about 10 or 12 residents that are interested in trauma. So they started this writing group. And I don't like the name they came up with it. I was like, okay, whatever. But it's SWAT, Surgeons Writing About Trauma. And they started this whole big thing. And I was like, okay, fine. And they come up with their own ideas and their own projects. And we're like almost 2 years old now. And we went from having like 5 or 6 residents to now, these are old pictures, pre-corona pictures, right? But so now when we have our meeting, we've got about 15 medical students and like 20 residents. And we have EMED residents and interventional radiology fellows and anesthesia residents that are coming now. And we had a couple of the residents actually got papers on AAST and got to go to the meeting, and present their stuff there. Man, so like in 2 years, these residents have like published like 20 manuscripts in 2 years based on just all resident. The first 5 or 6 were kind of case reports, simple things, but it got people going. We had an intern like write a case report and get it published, and they were like so excited. And it's not high science, but the enthusiasm and the engagement is huge. And so this has been great fun. We're dying to get back together and meet in person, but we've still been doing Zoom meetings. And then Jeff here, who's presenting up here in the corner, he's presenting at AAST, and Josh, another one of our residents, they both actually have podium presentations at the AAST next month. So it's been a lot of fun, and it's just a way to like really get people going and engaging, so it keeps me on my toes. And like I said, I started listening to podcasts. Obviously, Malcolm Gladwell's revisionist history is like a lot of fun. He looks a little crazy, and he is a little crazy, but it's a lot of fun. And then my other one I got into recently is Seen on Radio, and this is out of a guy out of Duke in their Center for Documentary Studies. And I just found this one. It's like on a couple years old. I'm getting caught up. So season 2 which was done in 2017, was all on seeing white. It was about being white in America, and it was amazing. So it's done 3 years ago, and it's incredibly timely. I think been a lot going on lately. I think everybody, like every white person in America should listen to season 2 on Seen on Radio. And then season 3 is actually about masculinity and misogyny, and it all came about after the Me Too movement. So it's another one. I got about 2 more episodes to go on that, which I'll do on the way home this afternoon. But it's also really, really excellent thing to listen to. So this has been like 2 things. So again, getting back to this article, what embodies an effective educator? One thing sort of buried in this manuscript was this line, which is residents contribute to making the faculty effective educator. So I do think it's a requirement of the residents to inspire your faculty. Like they should want to teach you. Like you should be such an awesome resident, so hardworking, and so engaged that I should be embarrassed not to teach you. And this is the one thing, like, if I could change a little bit about our residents. I'm going to start harping on them on this one, right? And so if your attending isn't teaching you, maybe some of it is on you. A lot of it's going to be on them, but maybe some of it's is something that you could do. So I do think this is this kind of this mutual relationship thing. So a great resident should inspire their faculty. So I do think there are some requirements of the learner to be engaged. And as Dr. Seuss said, the more you learn, the more places you'll go. If you're going to find great Dr. Seuss quotes for almost anything. So again, what is learning? Well, it's the acquisition of knowledge or skills through experience, study, or being taught. So what does it require to be an effective learner? Well, one, you have to be self-directed, right? You got to be able to learn yourself, do your own thing, teach your own self. You have to be inquisitive and curious. You should always be sort of insatiable curiosity. You have to be self-aware and honest with yourself. What do I need to learn? What am I good at? What am I not good at? Where do I need to improve? Got to be risk-taking. Yeah, and you got to be afraid of not making some mistakes. Actually, take some risks is rule number 7 in my 9 rules. So you got to be willing to take some risk, and so you got to be willing to be wrong sometimes, and you got to throw an idea out there. And your attending may not agree, but at least you got to be willing to take that risk. And then you have to be open-minded, because you have to know that you gotta learn. Which is rule number 6, which humility solves most problems. So to actually learn, you have to have some humility. You got to know that you need to learn, and that you have new things to learn too. So my advice to trainees. Now, before I get to that, I do have to warn you that I say a lot of crap. This is actually in our trauma office. So speaking Spanish, our nurses have this one up. Actually, one says your age should not be higher than your activation level. Dr. Kalka knows what I mean. Our traumas are called 95, 97, and 99. I don't know why, just always that way. So I'm like, if you're older than 99, you should not be a major trauma activation. I'm sorry. I know it's ageism, but rule number 2: when you get transfers, they're always twice as sick or half as interesting as they were advertised. I say this one a lot. I've already lost interest. The residents call me with a consult. Dr. Spain, this is an 83-year-old man with metastatic stage 4 cancer. I've already lost interest. And then this one's just kind of random, but if you ride a scooter in Europe, you look cool, but you cannot look cool riding a scooter in the United States. You just look too serious. So I say a lot of crap, so maybe you don't want to necessarily listen to what I say, but I do think for the residents, you should be a voracious reader. Find a textbook you like, and then set up a reading program. I had one when I was a resident. I don't remember what it was, but it was like, I'm going to read I read Schwartz, whatever. I'm going to read one chapter in Schwartz every month. It's going to get through a chapter every month. And set small goals. Even that was in retrospect, I probably wouldn't do that one. I would say, I'm going to read 15 minutes 3 times a week. Something simple and easy. Get a journal you like and skim the table of contents, and then find some articles in there you want to read in depth. I would, if it was a resident, I'd focus on sort of clinical trials or consensus guidelines. I don't know that I would, read a lot of basic science articles. Yes, you should, but for your clinical reading, focus on some of the practical things. And then, like I say, you should try to read outside of medicine. I never did this as when I was a resident. I must say I never read a single novel when I was a resident, which is pretty embarrassing. Be making rounds, people talk about the latest thing. But you should try and find a little time, at least some articles, and read some things outside of medicine. And again, you should want to inspire your attendings. And I think one thing I think surgery residents as a whole historically have always been pretty good about is actually teaching. Right? People actually have done studies years ago, and if you ask medical students 10 years later, who was your most memorable teacher in medical school, it was almost always a surgery chief resident. Now, you have a built-in advantage because you're usually PGY 5 or 7 or 8 or 12 or whatever. Here we are with some medicine chief residents like a PGY 2 or 3. So you have a built-in advantage, right? But surgery residents, I think as a whole, have been pretty good at teaching. But again, this is one of the things that you should work on as a resident. All right, so So when you do those Myers-Briggs tests, I'm what's called a quiet ENTP. What does that mean? I'm actually way more introverted than people think. And I experience most of my emotions internally and not so much externally. So I always say I'm pretty good at saying what I'm thinking. I'm terrible at saying what I'm feeling. But things have been crazy lately. There's just a lot going on in the world. And it's always easy to feel like you're living in unique times and things are so special right now. But I don't know, things really are different. I think we were talking last night to social isolation. We have a whole new class of interns come in. I haven't even seen them. I haven't met them in person. Like we used to, welcoming party. We go out to the, Dutch Goose and have a burger and a beer with our new intern, right? And none of that. Get up, go to work. And so I feel really bad, for our incoming interns that they haven't gotten that welcome. And other craziness going on, and unrest. And so the last couple of months, I've probably spent more time thinking and reading and self-reflecting than I ever have in my entire life. And as I said, I'm always not so good at saying what I'm feeling. So I'm trying to be more expressive. And one of the things I'm trying to express is gratitude. So, over the last 10 or 15 years, I've actually had the opportunity to develop some great friends and colleagues from UC Davis. So Dr. Farmer, one of the most genuine and authentic leaders I know. Jerry, who's been a true friend and an amazing mentor and supporter for me. A lot of what's happened to me in my career has been a result of Jerry's help and friendship. Joe Galante is just a solid rock with the highest integrity. David Cook, we get to know pretty well on the program committee as well. Just a great, humble servant leader. Tina Palmieri, fierce scientist, clear thinker. Matt Mell. Matt, those of you who don't know, at a stage in life that I would have not had the patience to do it, Matt went back to fellowship training and then pursued a master's degree so that he can now live his best professional life. And did it at an age and a time in his life, there's no way I could have done that. But he did the hard work. Dr. Callcutt, probably one of the most brilliant intensivists I know. She sees patients and makes diagnoses that I would never think of, and just has a way to figure out what's wrong with patients. Then Dr. Brown, Ian's a classic grinder. Man, he's just going to keep working and working and working until he gets the answer. Met Dr. Golame, who's one of our residents. Sep is a force of nature, just driven to succeed, will never take no for an answer. And then finally, Dr. Rinder Connect, the most emotionally intelligent resident I ever worked with, still to this day. And these are all great friends and colleagues that from UC Davis that I've been fortunate to have in my life over the last 10, 15, 20 years. And the one thing they all have in common is they're all great teachers who dare to teach. And as I said, things are a little bit crazy in the world, and it's easy to feel like it's pretty daunting. But I think can't be daunted by the enormity of the world's grief right now. So you have to do justly now, love mercy now, walk humbly now. You are not obligated to complete the work, but neither are you free to abandon it. It's just been a great honor to be here. I'm excited to spend some more time this morning with the residents, and most of all, to be able to pay homage to Felix Battistella, who was, without a doubt, one of the most exceptional teachers ever. Thank you.